Therapeutic Groups, Chapter 34. These are the terms that you're going to need to know, along with some therapeutic factors that we'll be talking about that you'll need to be able to recognize and be able to pick out terms and concepts in a situation on your exams. So our objectives here is to be able to identify basic concepts related to group work, describe phases of group development, define task and maintenance roles of group members, discuss Yoham's therapeutic factors, discuss 7 types of group commonly led by basic level nurses, describe group interventions for members who silent members, demoralizing members, and a couple other components of disruptive type of group members and how to manage them in a group setting. So psychiatric nurse Ben and Ardra want to start a support group for teens with HIV. Their goal is not only to offer health education, but to provide a safe place for teens to share their fears and concerns, hopes, and encouragement. They have determined that there is sufficient interest based on the feedback from their city's health centers. So they will most likely choose to meet in one area of a mental health clinic or a church meeting rooms. So looking at this right now, they have a goal to offer health education. Their focus is for teens, and their goal is to have them share their fears, their concerns, their hope, and encouragement, and it's specifically for teens with HIV. Okay, so this is a very specific group. So therapeutic factors, okay, when we talk about therapeutic factors, this is all part of Irvin Yoham, okay. He was an existential psychiatrist, God, I can't even talk today, guys, sorry about that, who developed and specified the specific approaches that we use in psychosocial therapy that started and created core principles, okay? These are factors that are curative factors, that are healing factors in a group setting, okay? That are crucial to create change. So we're going to talk about those in just a few moments here. So with these factors that we're looking at, we want to work with this group to see what's happening on the surface and what's going on underneath. The content is what's happening on the surface. So this is kind of what we're talking about on the surface. But then what is the process? What's going on underneath? How is it growing? How is it developing? Okay, so how is this developing? How is this growing? What is going on here? So when you look at page 612, table 3.4, some of those therapeutic factors that are curative, what we're talking about is universality occurring, instilling hope, imparting information. The group members are working together to create these moments of time where all of a sudden a patient says, I didn't realize that other people feel this the same way I do. That's an example of universality, okay? Or another patient says, if you can do that, I can do that too. That's installation of hope or installing hope. Or another patient says, well, here, this is how I take my medication so I don't get sick as often, because I used to get sick like that too. So this is what I did. That's imparting information. So characteristics that influence a group, okay? So how many people do you put into a group? You need to define the purpose of this group, and you need to look at the degree of similarities among its members. What are the rules going to be? What are the boundaries going to be? The content, what's said in the group, And the process is that underlying dynamic among the group members, because you're going to have cliques even inside a small little group. We're going to be buddies on this side, or this person's going to be on the outs. This person's going to have this role in the group. This person's going to have that role in the group. It's the process of how this whole dynamic works, okay? Just like a family, everybody has a role in a group, a role in the family. That's the same thing that's going to happen within a group setting, okay? So some other things about a group, there are advantages and disadvantages about a group. And on page 611, box 34.1, it talks about some of those advantages and disadvantages. So some of the advantages is you can treat many people at one time, and they can benefit from each other by different insight everybody has. It's shared all at once and gains further insight from each other instead of just one person. People can learn new ways to relate with each other and practice communication skills and promote feelings of being cohesive and not feeling so alone all the time. But there are disadvantages also to a group. Sometimes a person can feel cheated of time. I didn't get to talk because somebody else had the attention of the group. Or people worry about their privacy. Somebody will share something that was said in group. Or you could have a moment where somebody's being vulnerable and sharing and someone disrupts it because maybe they're uncomfortable. And so when somebody's being very vulnerable, they're squirmish and so they disrupt that moment. Or how about dissension within the group as they're talking and somebody decides they're going to break the ranks or cause conflict during that moment of time. And that brings in that cohesiveness issue. And not everybody always can benefit from a group. There are people when they are too acutely psychotic or in an acute manic phase or intoxicated, it is not the time to be in a group setting. So then, Johan, this is some of the stuff I was talking about, those curative factors or the therapeutic factors. These are a handful of them. I just started to talk about some of them. The catharsis factor that we were talking about, the aha moment. This experience has allowed me to get in touch with whatever the feeling they're having. By me talking about this, I have so much more understanding. Interpersonal learning. You need to recognize these terms, recognize them in a situation. Corrective recapitulation of primary family. Oh, this one's a powerful one. Okay. So you're in the middle of a group and somebody's talking and they're going on, and one of the patient looks at them and says, "So this is how you talk to your wife? Well, no wonder she's angry with you and wants a divorce." So what has happened is a patient has basically done a moment of countertransference with another patient in group, okay? And they are talking exactly how they would talk to their spouse in a group setting. And someone then says to them, "So this is how you talk to your wife." And so what they're doing at this moment of time is letting them know that it isn't okay. This is not how you do it. No wonder your wife's got problems with this going on and happening. And so this is a good learning moment and a good working moment for this patient. So these are those moments. These are learning moments of opportunity. And this is what we want to do. Okay? So we have phases of group development. Of course, and I'm going to compare this to a therapeutic relationship. Okay, so planning phase would be the pre-orientation phase in therapeutic. So planning, so we're creating the group. What's the purpose of the group? What are we doing? How are we doing? Orientation phase, greeting everybody. The leader of the group is setting the rules and the boundaries and setting the tone for the expectation of the group and the expectations. This is what we're doing. This is the structure. We're going to respect each other. That's confidentiality, trusting and stating the purpose. Okay, everybody introducing each other, getting to know each other. All that's going on in that orientation phase. And so we start the communication. So we move into the working phase where we start working on problem solving. And if you go to page 613, there are some terms that you need to be familiar with. One of them is called storming. Storming is where patients work on, well, they're going to disagree with each other, okay? And this is part of normal of working through relationships in a group. So there's going to be disagreements, and and one person's going to try to attempt to dominate over another, and personalities are going to clash. And we address this, and we work with this, and we talk, and the leader may question and help people work through this phase as they work through their conversations. Norming is what we do with just personalities. This is typical. Personalities are going to clash in disagreements, and this is where we let the members work into and settle into their respective roles, and they just talk it and work it through. And then you have performing groups, which is them and just working and achieving their goals and working through their factors. But these are all normal parts of group stages. But when it's storming and the conflict's rising strong, that's when the leader does step in. But in performing and in completion of tasks, we let the patients themselves work those through. Okay. Then, of course, you have your termination phase, and this is where we start to do the feedback component of referring the information and letting the members talk about how they affected one another, their losses, their anger, what they've learned from each other, and they share their insights and their accomplishments and their future goals. All the things that we would do when we're terminating a therapeutic relationship with our patient, we're doing the same thing with a group. And we start this a couple groups before the end of a group. We start that termination phase. So now we go into the planning phase in detail. So what are those things? Name of the group, the objectives, the type of patients, the diagnosis, the gender, the group schedule. How often are we meeting? How long are we meeting? What's going to be our physical setup? Do we want to sit around a table? Do we want to sit without tables? Are we sitting in a circle? How are we physically setting up the room? What kind of chairs are we sitting in? I've been in groups where we sat in recliners versus sitting in hard chairs. It all just depends what kind of sitting arrangements we set up for how long we're sitting up and what kind of a setting and purpose of our group. What are the responsibilities of the leaders and the members? What's the method of evaluating the outcomes? So how are we going to measure? Are we using a rating scale? How are we going to measure our effectiveness of this group? So then what type of membership is this group? Is it going to be heterosexual? Meaning we're going to be people of opposite sexes or same sexes? Are we homogeneous? Okay. Are we a closed group? So we restrict our members entering the group? Are we open group members? Or are we subgroup and isolating from within a larger group? Audra says she's concerned about whether a co-HIV support group will share as freely as one that all females or males. Ben feels it could work because she because he suspects very few conversations will be about sexuality. He feels the group will be far more focused on living with and managing HIV itself. After some discussion and pulling, however, they decide they have enough interest to conduct two different groups. Ben will work with males and Audra will work with females. Ben and Audra decide to create two completely independent, separate support groups. This means that Audra's group, consisting of adolescent girls with HIV, is what? A subgroup, an open group, a homogeneous group, or a heterogeneous group? If you select homogeneous group, you're right. That means all the members are sharing essential traits, meaning it's an all-girls group with HIV. So that means a homogeneous group, okay? Audra's group is not a subgroup of a larger, more heterogeneous group, okay? And a heterogeneous group would be containing different ranges of differences, okay? So, and it's not a shoot off of a smaller group. So it doesn't qualify for that. And an open group would mean that we would be allowing new members to be coming in, okay? So we're not meeting any of those other components. All right, so now we're going to talk about group roles, participant roles in this setting. So when we're looking at that, we are looking at page 614, table 34.3. So task roles are the participants' roles to keep the group focused on its main purpose. Okay, so that means we're talking about like the coordinator. This is the person who tries to connect various ideas and suggestions. The elaborator, that gives examples, meanings, and follow-ups of ideas. The energizers, that encourages the group to make decisions or take actions. The information giver, that provides facts or shares experiences as an authority figure. The opinion giver shares opinions, especially to influence groups' values. The orienteer, that basically notes the progress of the group towards the goals, etc., etc. There's a recorder. That person keeps notes and acts as the group's memory. So there's multiple roles in there. Those are just some of them. Then you have the maintenance roles. The maintenance roles keep the group together. They help others feel included and create a sense of group cohesiveness, okay? So there's the compromiser. So during conflict, they yield to preserve the group's harmony. There's the encourager, that helps praise and seek input from others. There's the follower, that agrees and follows the group. The gatekeeper, that monitors the participation of all the members and keep the communication open and equal. The group observers, that notes different aspects of the group's progress and reports in on the group. The harmonizer, that tries to mediate conflicts between members. And the standard setter, that verbalizes standards for the group. Okay. Then you have individual roles. Having nothing to do with helping the group, but instead they relate specific personalities, okay? Personal agendas and desires for having personal needs met. Sometimes these can be disruptive, okay, and cause issues within your group. But again, this is specific personalities. There are personal agendas that are going on here. So you could have an aggressor in the group that criticizes and attacks others' ideas and feelings. You can have a blocker that disagrees and halts the group's issues and opposes ideas. You can have a dominator that tries to control other members in the groups with flattery or interruptions. You can have a help seeker that asks for sympathy of the group excessively. You can have a playboy who acts disinterested in the group's progress. You can have a recognition seeker who seeks attention by boasting and discussing all their achievements all the time. You can have a self-confessor that verbalizes feelings of observation beyond the scope of the group's topic. You can have a special interest pleader that advocates for special groups using usually with own prejudice or biased. So we can see multiple things that can happen there. So Ben's group is very involved with lively discussions. Which of the following comments made by the members of a group best demonstrate a task role? I want to talk about how I got HIV. I'm having more trouble than anyone else in this group. 3 people were late for this group. Everyone is supposed to arrive on time. I can't believe you're talking about your girlfriend dumping you again. We started out talking about guilt, but we have strayed from that subject. D. Those that take the task role work to keep the group focused on the main purpose. So D would qualify for that task role. So now we're going to talk about theoretical foundations for a group. So when you're looking about what type of theorist, because we're going back to our theorists again, so a humanistic group theorist would be focusing on a person working towards self-actualization and awareness. A cognitive behavioral group would be working on changing maladaptive behaviors and thought patterns. A psychodynamic group would be working on gaining insight and resolution of intrapsychic conflict. A psychoeducational group would be working on information on a specific topic, coping or emotional and practical support. And a systems group would be working with social and political milieu. So they would be putting themselves in a setting of a political setting or a social setting where they would be interacting with people in that kind of a setting. So it wouldn't necessarily be a group per se, as it would be like going to a Republican convention center or a Democratic convention center and surround themselves in that milieu and having those conversations. That is on page 615, table 34.4. All right, so as a registered nurse, a registered nurse would hold and conduct a psychoeducational group, med education, health education group, dual diagnosis group, symptom management group, stress management, therapeutic community meeting, support and self-help groups, activities, and task groups. But an ARMP has more specialized training, so they can hold more complex groups such as psychotherapy, psychodrama groups, and dialectic behavioral groups. So, styles of leadership. So we have different types of leadership styles that hold different groups. And when you're holding a different group, you have to look at the style. And each style does different means and comes across a different way. And you're going to find that you like certain styles and you dislike certain styles. So an aristocratic leader, okay, or autocratic, some people like to pronounce it that, exert control over the group and does not encourage much interactions with the patients talking. So pretty much this is more of a lecture kind of discussion with little interaction from the patient. A democratic leader is someone who is going to support the group interaction. They'll talk a little bit, they're going to bring in part of the topic and conversation, but they're going to want the group to talk, and they're going to work towards problem solving, and it's a shared process going back and forth of discussion. A laissez-faire leader literally will walk in, sit down, and allows the group members to just start talking, choose the topic they want to talk, and just sits back and lets the interaction happen. And let the creative flow flow. This is a really good top thing to use, especially in like art therapy and let it creatively flow. Okay. So when you're using an autocratic or aristocratic, as I call it, um, agenda, usually that you use that when you have time limits, when you don't have where people could do a lot of talking and you're limited in what you're doing. You're going to then bring the topic in, have your discussion take place in a very controlled environment. Okay. Um, the democratic usually works very well in psychotherapy groups. Um, so each group is just a little bit different on where you want to use it, why you want to use it. So ethical issues for group therapy. Informed consent. You definitely want to have informed consent and make sure that people understand what we're doing. Groups, you need to have, in order to release information about the group, you need to have written informed consent. Otherwise, you're not going to release that information to just everybody. Confidentiality and exceptions to confidentiality. You need to explain what's said in group is kept in group. People should not be going out of group and discussing that outside of what was in group. Sometimes people will have private individual conversations, but it really should not occur amongst the group members. And you talk about rules about leaving group and socializing outside of group. You need to have set boundaries, because you are walking in. These are a group of strangers that have never met, and they're coming in and they are going to be talking about some of their most intimate feelings, about how they're feeling about themselves, maybe about their family, and they're sharing this, and all of a sudden they feel like they're best friends. Do you really want them sharing and socializing outside of group? There's going to be a piece of them that wants to do this, but do they really have healthy boundaries to be able to have a healthy relationship outside of this group? This is a group that's led by a licensed therapist that's making sure that boundaries are being maintained in this group. So do you really want them socializing outside of group? How ethical is that? These are things you want to talk about with these rules and with your group and these boundaries. When are members needing to be removed? What are appropriate trainings and credentials for somebody who is running a group? What about your group member or leader developing a relationship with a patient? American Nurses Association defining scope of practice. Evidence-based practice using cognitive behavioral therapy or didactic behavioral therapy when you're running your groups. These are all ethical issues that have to be defined, clarified, and maintained between you and your patients, and maintaining them. So dealing with a difficult patient that is in a group setting, because these are some specific components. You're going to find these on page 617 through 618, and look at table 34.6, the group leader and communication techniques. These are all some key components that will help you with being able to manage some of these elements with helping your patient, with using active listening, asking questions, giving information, clarification, confrontation, empathy, and reflecting, summarizing and supporting. This, again, all therapeutic communication that you use in a relationship. It's the same thing that you're going to be using in a group, and being able to just help a person deal with it. But I want to talk about how to manage a person in a group, because you do want to be able to recognize and be able to help a person deal with their emotion, and not embarrass them in a group, so that you end up having acting out that takes place. So let's talk about the monopolizing member. This is somebody who takes over a group and and is not allowing other people to be able to communicate during the group. So you need to remind, and one way of doing this is remind the entire group that we need to provide everybody an equal chance to contribute. And so you may need to speak directly to the member but privately when necessarily. You need to do this, to privately talk to that member and not embarrass them in front of everybody. So the reason they may be monopolizing is because this person is having anxiety and they're trying to manage their anxiety. They may not be doing this intentionally. And so just to say to the entire group, I need everybody to have a chance to talk right now. So Charles, what do you think at this moment about and point out and have this other person speak right now, and just kind of shut that other person down, and then privately talk to that person who's excessively talking and clarify what's going on with them and ask what is happening. I'm noticing you're talking a lot. Um, can you tell me what's happening? Okay. So this is one of the ways of helping manage what's taking place. Okay. Now, the demoralizing member. So this is where you need to be careful because you need to listen objectively, but at the same time, ask in private about the cause of their anger. Empathize, but be very matter of fact with this person. They're making the problem, let's see, how do I want to word this? Insurmountable. This person has their own conflicting feelings about their dependency or their connection with the group. So they're having a problem connecting. So if the leader is noticing this person's increase in self-esteem issues, they may have mistrust, they may have had rejection issues, okay? And so we need to acknowledge the pessimism, but stay neutral. Over time, they're going to recognize that they're having issues, okay? So you want to listen. You want to, again, really talk in private about the cause of their anger. But over time, they're going to change with this. Again, a lot of it is private. Listen, just keep moving forward without giving too much focus to it. Okay, acknowledge their feelings, acknowledge the conflict that they're having. And then there's the silent member. Okay, the silent member, determine the cause. Their cause may be a response to being uncomfortable in a group setting. They may need extra time to think about what they're experiencing and then come back to them with the response. So this is where they might not trust the group yet. They may have severe anxiety disorder. So you may have put out there, so what do you guys think about the la-la-da-da? And I'll say, Jim, I'm going to come back to you in a few minutes with the same question. So I want you to think about your response, and I'll come back to you and after Jim, or after Susie and Sally answer this question, to see what you think about this. And so those two will answer, and then I'll go, so Jim, now what do you think? And then have that person answer that question. So that gives them time and an opportunity to think about it before they answer their question. Okay. So, expected outcomes. In therapy groups, we're expecting the patients to get insight, work on behavioral changes, and reduction in symptoms. In medication groups, we're expecting awareness of side effects, awareness of interactions, and identifications of time and dose of each of their drugs. In support groups, these are different support groups and self-help groups that are out there: bereavement groups, suicide survivor groups, NAMI, National Associations for Mentally Ill groups for parents, or for patients and family support and education and advocacies. There's cancer support groups. There's veteran support groups. I'm just listing a few of them. There's also self-help groups like the 12-step groups for AA, Al-Anon, Narcotics Anonymous, Gambling Anonymous, Overeaters Anonymous, Codependency. There's Recovery Internationals. There's National Mental Health Consumers Self-Help Clearinghouse. There's so many different self-help groups that are out there that you guys can use, and resources. If you haven't found them, your book has a listing, and there's even a couple phone numbers in there. So here's some questions. Medication education and health education groups are what type of groups? Psychoeducational groups, insight orientation groups, support groups, or psychodrama groups? If you picked A, psychoeducational groups, that is correct. They're set up to increase your knowledge or skills, and they're specific psychological or somatic subjects that allow members to communicate emotional concerns. They're led typically by a psychiatric mental health nurse who are holistically trained and prepared to teach about a variety of health subjects.